And it's my great pleasure to introduce you all to our speaker for today, Marlene Benvenuto. And Marlene is an RN with nursing specialty certification in hospice palliative care. And Marlene has many years of experience here in Thunder Bay. So she's worked in long-term care, in hospice care at St. Joseph's Hospital Hospice Unit, and with the Northwest Regional Palliative Care Program. And currently, Marlene is a palliative care educator with Ontario Health at Home. And she is also a palliative care education facilitator here at SARA, as well as being a certified LEAP facilitator. So thank you so much for being with us, Marlene, and I will let you take it from here.
Thank you very much, Steph. Before I start the whole presentation, I would really be interested to find out, because our topic is what's in your toolbox about assessment tools, what tools do you currently use, if you use any in your practice, and if you could put them in the chat, and then we can kind of go from there and compare along our presentation, if that's okay with everybody. See what we've got here. So welcome everybody. And for today's presentation, for learning objectives, we'll be looking at the definition of palliative care, palliative approach to care, explaining the importance of dignity in care, as well as the importance of early identification. We're going to look at screening tools used to support early identification, as well as some symptom assessment tools, and if time permits, a case study.
So Marlene, before you jump ahead, we did have some answers come in. So people did say they're using the PPS, the ESAS. This is new information for some people. Gold Standards Framework, the SPIC tool, FICA. So that's great. The CHESS, Abby Payne. Yeah, some that I haven't heard of in there. So interesting.
Well, that's wonderful. Excellent. Thank you very much. So we'll start out with the definition. So palliative care is really more of a philosophy of care that aims to relieve suffering and improve that quality of living and dying. I want to ask everybody on the call today, when they've discussed palliative care or provided palliative care, what few words or 2 words came up when you were dealing with clients that they associated with palliative care? Be interesting to hear back from you, because it has evolved over the last few years as all this education. It'd be interesting to find out what people feel the connection is with palliative care. I'll give you my example first to kind of give you guys an idea. So when I first started out in palliative care, when someone heard my title as a palliative care consultant, they kind of gasped. And first 2 words were dying and cancer seemed to be the 2 popular words that were first disclosed to me. Now it's nice to see that when I ask this question, there's different phrases or words come through as like comfort measures, symptom management. So these education classes and the progression of learning about palliative care is really improving, I think, in my view.
I love this one, Marlene. Someone said dignity in dying and comfort care.
Excellent.
Yeah.
Excellent. So it's nice to know that the way of thinking is transitioning to where it should be going, right? For comfort measures and dignity and such. So continuing on, thank you for your participation in that. So palliative care really strives to help individuals and families to address issues in the physicality, psychological, social, spiritual, and practical issues, as well as associated expectations, those needs, hopes, and fears as well, right? And it helps in providing and supporting management for end-of-life choices and the dying process, as well as supporting coping with loss and grief, treat all active issues. And I think that can be displayed along someone's journey. So if a palliative care is provided, or a palliative approach, we'll go into that definition next slide, is initiated early, those active issues can be treated because they're mostly symptom management and education along how that can be helped and treated. Prevent new issues from occurring, and through ongoing assessments that can be helped. And promoting opportunities for meaningful and valuable experience, both personal and spiritual. Someone asked me, I don't understand how that could possibly be, but it really is, because when we go into some of the other slides and going forward, you'll see that physical symptoms are not the only symptoms that are dealt with, and how opportunities for meaningful experiences with family members can be very beautiful, especially when they're, say, estranged and now they reunite, as an example, or reuniting themselves with their spirituality or their religion and finding meaning in that. So palliative approach to care really is still palliative care, right? But it's earlier on in the trajectory of someone's illness. So it's meeting the person and their family's full range of needs. Once again, the physical, the psychosocial, spiritual aspect, in all stages of a chronic, progressive, life-limiting illness. It really enforces the person's autonomy and right to be actively involved in his or own care. And that's really important, right? We're along for the journey, but it's their journey. Strives to give individuals and families a greater sense of control, as well as approach to care that can enhance that quality of life throughout the course of the illness or the process of aging. So literature supports that when we use a palliative approach and have truthful conversations about what to expect at end of life and along the journey, patients and families really have less stress and anxiety, and actually have less pain and symptom issues, and can experience an extended life experience of 3 months or longer, depending on the situation and depending on the individuals. And what we do know is a palliative care approach can be provided alongside treatments. It's not one or the other. It can be provided along. So it provides that opportunity to engage in conversation, to improve the patient's understanding of their illness. It also allows space to identify the patient's values and goals with their loved ones and the healthcare team. And that open conversation really earlier, open conversation occurring earlier in a progressive life-limiting illness can really help to anticipate that patient's needs, could minimize the unnecessary emergency department visits or hospitalizations, because dealing with what their values are and what their goals are. It also reinforces the person's autonomy and the right to actively be involved in their care. I like this diagram, the domains of holistic care, and Stephanie knows I like this diagram. When we look at someone holistically, we not just looking at their disease or their pain and symptoms, but we're looking at them as a whole person, right? So I want you to take a minute or so just to think of a situation that perhaps even personally or while you're working, how you perhaps have witnessed that. And I'll give you an example of how you may see this, or how they're all intertwined, all these domains. So someone that has a disease, pain and symptoms, or their physical activity is diminished, or their functionability is diminished as well. How would you think that would impact someone psychologically? How have you seen, or how do you think it might impact them that way? addressing their emotions. How would that affect their emotions? How would that affect their control and dignity? Really, their self-image. Uh, how do they cope with that? Or, losing that ability. How do they deal with that loss of not being the person they once were, or those uncontrolled symptoms? And then you can go one step further and see how that might impact someone spiritually, um, their beliefs, their meanings and values. Uh, Once again, their life transitions or their loss and grief, maybe losing their meaning of why me, why this, how come it's happening, right? And how that impacts somebody questioning their spirituality. And then even looking further into their social cultural aspect of their world, excuse me, how that physical, say, disease may impact them socially. It can impact them through finances. Maybe they're the person that in the family unit that supports the families financially and now are not able to work. It may impact their relationships with the immediate family or friends and family outside their home, impacting their personal routines. Can you think of how that might impact them if they're not able to go out? They may not be able to go to recreational events, maybe because of their ambulation. Maybe it's limiting them. Maybe looking at their emotions and their self-esteem and their dignity, thinking that they can't do it. As well as family caregiver support, how that impacts that, changing the roles of family members, as well as looking elsewhere outside the family unit for support. So see how all that can have an impact on someone's life, a symptom or a disease that kind of goes into all aspects of one life. It's not just the physical. So we have to look at, I think that's the key point of this diagram, is how it impacts and how we have to look at the person holistically in all areas, because sometimes we can't help in certain situations if we don't know how it's impacting them, right? Anybody experienced that or seen that, where the physical aspect of someone has impacted them psychologically or socially or spiritually? And I have to say, from what I've seen personally, sometimes the psychological and the spiritual um, issues that are brought to light are far more challenging at times than the physical issues, or can contribute to the physical issues. I also like this diagram because when we're talking about palliative approach, it's a visual where you can see how you can implement that discussion. So as I indicated in one of the other slides, palliative approach can work alongside other therapies. So when I'm discussing about how it can be introduced at the beginning of someone's diagnosis or presentation of their life-limiting disease, that may look like maybe education, having those conversations about understanding what they understand in their disease process, or what's important to them, right? This is a good area that, say, advanced care planning could be started, just to have those open conversations. Now, in saying that, conversation is the key throughout the journey, to have those open conversations as the disease enhances and they're transitioning to more of a palliative approach rather than treatment or therapy. You can see over time how the palliative is kind of more introduced, and to help relieve that suffering, whether it's physical or emotional or psychological, to provide that quality of life, right? And then closer to the end of one's life, introducing prior to that, in that transitional state, education about what that may look like and how to support those individuals and their families. And it just doesn't end at the death of the patient. There's that grief and bereavement care following one's death to everyone, the family, the friends, and even if they're in a hospital-like setting or a long-term care setting, that could even be supporting the staff as well. Any questions so far? No? Okay. So why focus on dignity? I think someone had written dignity down in the chat when I asked for those words, right? Oh, I see a raised hand.
Yep, you can go ahead and you should be able to unmute yourself, Esther.
Oh yeah, I was just going to make a comment when so I most recently worked in a hospice. So I've been working with end of life for actually quite a while, but I just wanted to comment on what you were saying about physical pain and social psychological. If you look at the data for MAID requests, one of the number one reasons that people are requesting MAID is for those areas. It's not for physical pain. It's usually the psychological or existential. So I think we need to make sure that we don't get caught up in the physical and recognize that those other areas are actually the reasons why people are actually, asking to end their lives.
Right. I've had patients say, oh, my heart hurts. And you, like you're saying, automatically think, oh, they're having chest pain. And then when you delve into it a little bit further, their heart is hurting because of their pain that they're experiencing for numerous reasons, whether it's the fear of what's next after they die, or the fear of how their family's going to cope afterwards. So you're right. It's really, sometimes it can be really hard to decipher what is caused by what. Thank you for sharing that. So why focus on dignity? Dignity is that quality of being worthy of honor and respect and self-respect, right? If anybody knows me, this is really important to me. And so I stress it. And why am I putting it in this section is I think it's the foundation of having any type of conversations, whether it's with early identification or with it's providing those assessments. We have to build the foundation, and that's built on respect and trust. And that's why I'm adding it in here. I think it's very important. And that attitudes and behaviors really can influence and shape important reflections. People want to be seen as people, right? They don't want to be seen as their medical illness. And statistics have shown that a personal sense of dignity can make the difference between a person's wish to live or to die. And that I really believe that. What I've added here is the website for dignity and care. And I'm just going to kind of go through a little brief summation of some of the parts of dignity and the model of care. So the principles for care that enhances dignity, the healthcare team really can do many things to help buffer that negative influence on a person's sense of dignity. And by what I mean is by affirming their value, make the person feel that they're seen as a person, that they were or are, rather than just their medical concern. And viewing people apart from their disease is really important. And by having communication or affirm those aspects of their personhood, they're not affected by their illness. They're additional to their illness. They're much more than that, much, much more. Safeguarding the person's privacy, to remember that procedures may be routine to us who work in the health field, but may not be routine for most of the patients. And we have to be mindful of that. We also have to address their pain and discomfort. Oops, sorry. Pardon me for a moment. deal with their fears and anxieties, and help them maintain that feeling of control and independence. We're there to help them, and it's a privilege to do that because they're allowing us in a time that is very difficult for them and very um, leaving themselves wide open, right? So when they allow us to work alongside them and help them, they're allowing us in a very sensitive and endearing spot to themselves. So we have to be mindful of that, really. We also have to perhaps encourage the involvement of the family and the healthcare providers as well as spiritual practitioners. So I just want to quickly review over the ABCDs of dignity and care. So attitude, how we have preconceived ideas or how that can impact our actions. So we have to be mindful of that. I always would think of myself and say, how would I react to this? Or how would I feel if someone reacted a certain way to me in this situation? And it makes me think. And when before I go into a room to see a patient, I would kind of just go, okay, this is their space and their journey, and I have to be able to listen to what they have to say and accept what they say as what's important to them, not my preconceived idea of what's important. Behaviors, we have to be kind and respectful, and that's a given, right? But simple gestures can really make a patient feel more like a person worthy of attention and respect. And it's just those small acts of kindness and respect can really enhance the conversations. So I'll digress a little bit and just make a little comment about when I would have a new admission to the unit. I would try to cordon off as 15 to 20 minutes of time to sit down and give them undivided time and get to know them as a person, understand, their family dynamics if they care to share, but bringing them that comfort and that safety, that way I can have that conversation with them, allowed the environment to be safe enough for them to disclose things, right? And to build that trust from that base is key, because I think trust and communication is the foundation of anything that we do within our nursing careers to address the needs of our clients. And I find that so important because when it comes down to those real difficult conversations, that trust is already hopefully built in place there. So those conversations aren't going to be they're going to be challenging, but they may not be as challenging as having a conversation when you first meet somebody as someone's actively dying, right? It's building that trust along the way. It really goes the distance. So small acts of kindness and respect can enhance that trust and that connection. So as I said, so in turn, patients may be more comfortable in providing doctors and caregivers that important information that can have a bearing on their ongoing care. Compassion. I think anybody in nursing has that compassion and empathy, but also the dialogue. Communication is the first step towards understanding. I wanted to add this slide because for those who probably already know Dr. Harvey Chochnov and his development of this dignity and care, this question is really a good opener that you can use by getting to know the person before you get into the down and dirty, shall I say, of the heavy conversations and those heavy questions. Just kind of breaking the ice and tell me, what do I need to know about you as a person to give you that best care possible? That's so much nicer approach and getting to know more than what you think you're going to find out in those smaller conversations than a tick box and asking those questions, right? So the dignity model identifies really three key domains that influence a person's sense of dignity: that illness-related concerns, factors like loss of independence, distressing symptoms, anxiety can undermine dignity, right? And dignity conserving repertoires, like how does that person themselves, what type of strategies do they have or perspectives that help them maintain their dignity? And then the social dignity inventory, that impact of interactions with others on a person's dignity, really like the key principles of respect, communication, autonomy, empowering them to have control and make decisions of their care. And that privacy, upholding that, the right to privacy during their personal care and perhaps even other sensitive situations. And then fostering a respectful environment and culture of dignity within that setting that you're conducting all that.
Marlene,
Yes.
you did have a question come in while you were speaking there. And it was, what experiences do you have in using these strategies to promote dignity with Inuit people, if any? Do you find it more difficult to build relationships with Inuit people? And are there any other tools you find helpful in these relationships?
Okay, I'll have to think. I think it takes a little bit longer because of the distrust in some communities. So it'd be more of a slower approach. Get to understand, ask them permission if, being honest and upfront, I'm not too familiar with your culture, and I'd be interested in hearing more about your culture. Kind of not go right into the nitty-gritty of things, but getting to know them and their culture and what is important in their culture is really key. Once again, it's still building that trust. It may just take a little bit longer. And I think what's helpful is, from what I've experienced, is by listening to the stories, giving them that time and that space to tell you about their stories, you get more out of their stories sometimes to move forward. And that might be the first visit, just listening to the stories, and then come back again and hear a few more stories to get into those discussions. Is that kind of helpful? I know that worked for me. Was pacing myself, not looking at a task that had to be completed. It was, if it takes me 2 or 3 times, depending on the situation, it may take that long just to get people to be comfortable with the environment and talking, right?
That's helpful. Thank you.
So communication really is the first step towards understanding, right? It's that constant exchange. And I think, once again, fostering that sense of trust, openness, and honesty can really increase that likelihood that someone will share their important details. And it might come up even in a conversation, looking even at a picture, going, oh, tell me about your family. And next thing you know, they're saying, oh, well, they were sick last year and they've had this, and then asking those questions. What was wrong with them? Would you like to share that with me? And find out there's a history that the individual that I'm speaking to, there's a history of that illness in the family. So you're connecting the dots, but in a slower way, right? So
Someone did raise a good point though, Marlene, with the comment that with some cultures, it might be more appropriate to talk with designated family members. This person has worked with cultures that do not appreciate having questions asked.
and you would find out right away from the first visit if that wasn't something that's approachable. So yeah, to go back into the care plan and see, or ask them, how can we, not familiar with how we go about, who do I speak to if I'm unable to speak with you, or, at some point may even bring in the family members to speak as well. It all depends on what the person wants or is interested in partaking, right? It's a challenge. I'm not going to say it's just go in there and do a checkbox. It's so individual, right? Some cultures, even there's differences within the cultures. Some personalities will be okay with that, and then others are more strict and not wanting to talk directly with, the staff. So what I wanted to really show you in this communication slide here is that we also have to look and acknowledge that that person's disease, it goes beyond their affliction, right? And how it impacts them emotionally as well. Going back to that holistic slide, an example, it can be as easy, and I won't say simple for lack of a better word, but someone who's suffering from a severe arthritis, you go, oh, that severe arthritis, okay, yeah, that's life limiting. But to find out in conversation that perhaps that person was an avid pianist and that was their occupation. Now go back to that holistic diagram and see how that's impacting them, right? Maybe impacting their dignity, self-esteem, financial, their emotional, how they're going to cope with all of it, right? Additional to the severity of their illness. So there's I just wanted to add those couple of examples because we seem to forget how that ties into the rest of someone's life and how it impacts them. So the tools we're going to be talking about today, the screening tools, I'm going to be addressing more the early identification and prognostic indicator guide that's been adapted from the gold standard framework from the UK, but also to mention that there is the SPIC tool, the supportive and palliative indicator tool that also comes from the UK. I believe it's Scotland. Just for time restraints, I thought I would use the early identification one because it seems to be more readily used, although it has been indicated on the chat that people have used that as well. Also for the assessment tools, I'm aware of the chess and what was the other one that you had said, Steph?
The Abbey, that was the one I hadn't really heard of, but
I've not heard too
up.
much of that. I've read of it, but
It's Australian apparently.
yeah. So for today's session, will speak on these ones here. Okay. So early identification, really, individuals who have a progressive life-limiting illness should have their palliative care needs identified early through that comprehensive and holistic assessment. Initiation of a palliative care should not really be determined by their prognosis. So it can, as I indicated in that one diagram of palliative approach to care or early identification can be as early as the time of diagnosis. And as like in the diagram I discussed with you, it can be added alongside the treatments. It's deliberate, a proactive, decisive point in a person's healthcare journey, right? And it should include assessing all their needs. Once again, I know I'm repeating myself, but it's so important to look at the person in entirety, not just the physical, but all those other needs. And that open conversation with the individual and their family is really essential and should include goals of care discussion, as well as education and assessing their needs along their journey. So conversations really can be more meaningful and thoughtful when they're pre-planned along one's journey, rather than in a period of crisis or rapid decline. There's heightened emotions. It's hard to process all that at the one time. where if it's kind of pre-planned when emotions are less elevated and they can absorb and understand the conversations and provide their input of what's important to them, right? And it's all about the patient. So we need to hear what their concerns are, what their goals are, their values. And that as well can change along the journey of the illness. So someone's goals and values and hopes and fears might be one type of topic at the beginning of the journey, but as they progress, their hopes and their fears and their goals might change. It's a moving target, shall I say. And so those ongoing conversations throughout the journey can help lead to better quality of life along the process. So what we've discovered is that when those conversations are included, there's improved satisfaction with the end of life care, improved pain and symptom control, because of those conversations and those assessments are ongoing. And there's decreased visits to the emergency department or hospitalization because of those discussions, understanding if that client wants to go to the hospital or what can we provide, say in a home care setting or in the setting that they're living, versus the hospital setting. So I know a lot of it is repetition, but you can see how important that engagement of conversation to see how much that patient's understanding of their illness is. It's surprising when, if you use open-ended questions, you get a lot more information than a yes or no question. And you can explore what they understand or what they don't understand, or how much they're interested in learning, or maybe just learning bits at a time along that journey. When open conversations, once again, are earlier in the progressive illness, it really is helpful to how we can anticipate what their needs are, right? And then it reinforces their autonomy and their right to be involved in their care and making those informed choices when they're still able to make those choices and being their voice for themselves. So the process of early identification is three parts: to identify who might benefit early in their illness trajectory and may not need a palliative care specialist. Assessment, assess all their current and future needs and the preferences of the individual and their caregivers and family across, once again, all those domains that we've been speaking about. And then making or developing a care plan, collaborating with other healthcare providers to address those needs identified in the assessment. So from what I gather, there are a lot of people are using the gold standard frame, right? So is a lot of people familiar with the three triggers that suggest that people would benefit from a palliative approach? So who has used the surprise question or thought of that surprise question? Would you be surprised if the patient were to die in the next year? I kind of think we do it intuitively. Sometimes when you're working on a floor for individuals that work in a hospital-like setting or a long-term care setting, and you see the changes and you're going, yeah, I wouldn't be surprised that they're not going to be here next year or in a few months, right? I think we intuitively do it when we assess people. So that's the first question. And then we'll talk about the general indicators of decline that may be noted in deterioration or advancement of their disease, maybe decreased response, and perhaps even a choice of no further treatments. And then we'll look at the specific clinical indicators to certain conditions. I've also included the website for the gold standard framework if anybody wanted to view it as well in their leisure afterwards. I'm a visual person, so I wanted to add the gold standard framework algorithm in supporting the care planning. So when you ask yourself that question, would you be surprised if your patient were to die in the next year? And if you were surprised, then you just continue reassessing on a regular basis. But if it's no, or you're not sure, then you'd be looking at the general indicators of decline that we're going to be going through in the next slide. And then if it was yes, you would do your assessments, right, in all areas and have those discussions, perhaps goals of care, depending on where they are in their illness, and even begin that advanced care planning discussion with the team and family members, as well as most importantly, the client. And then develop a plan from what the assessment indicated. But if the answer is no, then you look for more specific indicators. And once again, there'll be a slide a few up from now that we'll go through it. And if it's no, then once again, it still is opportunity to have those advanced care planning discussions, planting that seed. Don't have to get it all said and done, but just give them the thought and have you thought about this, or have you thought about who would be able to be your voice when you're no longer able to speak? That's it. That's a seed that they can plant, and the next time you visit, you can, go more in depth. And if the specific indicators, once again, as I said, follow the assessments and what came out of the assessments and develop a plan from there. So some of the general indicators of decline with increasing needs. So once again, that advancing disease, unstable, deteriorating complex system burden, a decreasing response to treatments. Maybe they've chosen no further treatments, and you see a general decline in them. If they're declining functional performance status, or their PPS is 60% or less, having reduced ambulation, increasing requirement for someone to assist them with their activities of daily life, their living. Do they have comorbidities? A lot, as people age, have more than one illness. They have, or the disease is, developing. So now it's affecting more organs or systems. So that's one of the bigger predictive indicators of mortality and morbidity. Is there weight loss? Is there greater than 10% and it says 6 months, but I like to think of maybe 3 to 6 months, depending on how fast you see that change in their weight. Or those repeated unplanned crisis emergency department visits or hospitalizations. I really think that if someone is, and this is my own personal view, if someone has been to the hospital three or more times in, say, a span of 3 months to 6 months, they should be flagged in the emergency to look and say maybe they need some palliative approach to care, right? What do they understand? More investigations on what they understand and how that can be benefiting them to have those discussions, right? Sentinel events, maybe a serious fall has happened, or bereavements, perhaps they've retired due to medical conditions. Any questions or anything so far? Oh, we're good. So this slide is just showing you the varying disease trajectories and the 3 most common ones are cancer, organ system failure, and frailty and dementia. So on the left with the cancer, that's more of a incurable cancer. It can be of a rapid or predictable decline, metastatic cancer. I have to say that with this graph, this time frame can be a few years, but when they decline, it's a rather quicker decline. You can see by the slope on the decline. So the single most important predictor factor in cancer is the performance status and the functional ability. So if the patient is spending more than 50% of their time in bed, laying down where they hadn't been before, prognosis is usually estimated to be about 3 months or less. I know on the diagram it says less than 2 months, but once again, it varies from person to person. So for the organ system failure, it's more of an erratic decline. I like to use the examples of a lung disease or COPD, because that's so visual when someone's having those respiratory exacerbations. And it's more of an erratic decline. And that could be a period of time of 2 to 5 years. But generally, death happens suddenly in this trajectory. So what you'll see is they've had an exacerbation, they've declined, they've been treated in a hospital setting, more likely, but they never quite recover back up to what they were previously. So it's a downward, slower slope to their health declining. So each exacerbation limits them a little bit more and more until closer to the end of their illness, where they may have the spacing between each exacerbation may be a shorter period of time. And when it gets to this point, you're not quite sure if that last exacerbation may be the cause of their death. So with the last one, the frailty, you can see by the graph itself, it's of a longer duration, usually 6 to 8 years or up to. And its onset usually starts with deficits in ADLs, their activities of daily living, perhaps even a deterioration in their functional performance. And then they may just slow down in their movements. They may have significant weight loss in this area. Whereas as well as with dementia, they're losing that ability to walk without assistance. They now may become incontinent of urine and feces, total care, bedbound, and at risk for increased risk for urinary tract infections, pressure sores if they're bedbound, as well as reduced intake or even a greater risk of aspiration pneumonia as things progress with their illness. So you can definitely see there's 3 defined disease trajectories that are the most common. And sounds like everybody already uses the Palliative Performance Scale. Is that my understanding?
I think people are fairly familiar with it. We did have a question though, Marlene,
Okay.
if this is the latest version of the PPS, which I think it is, right?
I think version 2 is. I haven't come across a version 3 yet.
Thank you. And I'm just going to flag, Marlene, we have about 8 minutes left. So,
Okay. So I guess we'll just do a quick review of this. So how the scores are determined is you see the 5 columns plus the PPS levels. So you start with ambulation. That's the most strongest determinant of the functional ability scale. So if you would say someone was reduced, then you'd move to the next one at the same level and try to find the best fit and go so forth all the way down across to the end. But keeping in mind that the left side of the columns are the stronger determinants and generally have precedence over the others. Also that the PPS levels are only in 10% increments. They're not, you won't see a 45 or a 55. You have to basically determine what's the best fit in your estimate on gauging on the person by using the left and right columns, which is the most determinant, sorry. So PPS is a good communication tool. If I was to speak with Stephanie and say Mrs. Jones was 50% last time I was on shift, and I noticed today that she's 40% today, she would know that there's been a change in her functional status and that maybe we need to further investigate what's the cause or if that's signaling decline in her condition. It's also used as, in some situations, as a workload determinant. So if you had 5 clients and they were all 30% and your coworker had 5 clients, but they were 70, you would know that you would need more assistance in caring for your clients versus someone with 70%, that they would not need as much attention and care because of where they were in their disease process. So, FICA assessment tool. I'm so glad that some of you have indicated that you use the spiritual assessment tool. So it looks at faith, the benefits of it, the importance and the influence of it, community, and addressing those care issues. So by asking how important is your faith, who supports you in the community, or even as far as how do you use faith in your providing your care for yourself? I have 2 quick stories in regards to how important this is that I used it quite a bit. I had 2 situations, and I've had many more, but these 2 stick out to me. One gentleman that had extreme bone mets and a lot of pain with it, and very religious, and he would refuse pain medication or additional pain medication because in his belief, in his faith, that he had to suffer to get to heaven. So he had to experience all this pain before he was allowed to enter. And it was very challenging to get increased medication for pain relief for him. And the other one that really resonates with me was another little lady that was of the Catholic faith. And there's nothing to say about the Catholic faith. It just happened to be 2 people that had the Catholic faith, that she indicated to me that growing up and through her life, that it was always told to her that in marriage, being of the Catholic faith, you couldn't divorce. If you were divorced, you'd go to hell. And she had been divorced 30 plus years before this, her illness in the hospice. And when we spoke, she conveyed that to me, and her fear was so great of dying and going to hell that she hung on for so long. With her approval, I was able to reach out to a spiritual advisor who came and spoke with her. And after their conversation, about a couple of hours later, she died. So that's how important I believe the spiritual assessment tool is, and how impactful it is for people in their journey. And once again, going back to that holistic diagram, how important it is. And that pain for her was very, very real. The clinical frailty scale, that's a good visual scale. 1 being very fit, 8 being very severely frail, and 9 having a life expectancy of less than 6 months. I think a lot of nursing homes use this one. At least they did when I worked in a nursing home, but that was many moons ago. The ESAS, or Edmonton Symptom Assessment System. So this tool was developed to assist in assessment of the 9 most common symptoms in palliative care patients, as you can see. And its intent was to capture the person's perspective on symptoms. But in some situations, you had to get the information from caregivers. But the main focus would be the patient providing the information, because it is about them. And they would give you the best information on how they rate the scales from 0 to 10. So those repeated assessments can help track the changes in the symptom severity over time. And it's just one little segment of holistic clinical assessments. So I understand some of the people on today's presentation have used this quite often. It's usually used, I've seen it used in the cancer care palliative clinics, as well as the palliative care non-cancerous clinics in Thunder Bay, additional to the units as well, especially the hospice unit. A pain assessment is always necessary, and I like the OPQRST assessment one because it's asking those open-ended questions, so you can get more detail out of it, and it's from the person themselves. The onset, the provoking factors, the quality, regions on where it's located, time and treatment, severity, and their understanding in impact. Sometimes I'll see on these pain assessments, a V is added for the values. You get more information that can help problem solve, right? The PENAD scale, pain assessment in advanced dementia. This has got 5 categories, observational tools that can be used, and 0 is the norm. And then it progresses up 1, 2 in regards to what you see. So I'll just give an example of one of them. So the breathing independence, what you observe, what you hear. Is the breathing labored? Are they hyperventilating, right? And for more distress, you may see a more labored breathing, a longer period of hyperventilation, or maybe even a difference in their breathing patterns, right? For body language, they may be tense, they may be pacing or fidgety, or they may be just clenching themselves, holding their body closer with their extremities, or striking out. So those are some of the examples. And I think we can use this additional to advanced dementia. We can use this on an observation when we see patients that are in pain. We look for their breathing and how they're breathing. How are they vocalizing their facial expressions, whether it's a grimace or a frown, or their flat effect. Body language is important, and that consolability, right? So this is one for both advanced and part of our regular assessment as well, I think. These are the standard ones. I wanted to add the numerical one and the Wong Baker facial grimacing scale. The facial scale can be used for people that are not able to tell you how they feel or what the number is, but point to the face on how they feel. Or children can point to those diagrams. And the number scale, right? Rating where their pain is and help you out. And patients where they'll tell me, I'm rating your scale from 0 to 10. How do you find your pain? Oh, it's an 8. I said, would you like something for it? No, I'm good. I'm good. So it's sometimes it's challenging to convince them, and sometimes they have a higher threshold of pain as well. The confusion assessment method, the CAM scale. This is a tool that's used to diagnose delirium. So you can see that there's the features: acute onset and fluctuating in course. The second one, the intention, difficulty focusing, easily distracted. And then number 3 and 4, either disorganized thinking, thoughts, or an altered level of consciousness. We do know that delirium, and I'll just touch on it briefly, delirium has not just one aspect to it. There's a varied aspects to it. There's hypodelirium, there's hyperdelirium, and there's a mixed delirium. So sometimes it can be challenging. So for this scale here that I've included, the highest scale would be 7, where the longer scale, I believe it's 19. On that scale, but it kind of gives you an idea of the severity of the delirium with this scale. Do we have time for the case study? No. Okay, well, maybe when the slides are distributed, they can review the case study.
Yeah, I think that's a good idea. And then kind of the idea was to see what assessment tools you might apply at what point, I think, right?
Yes. And where they would fit in, like where would you, what kind of questions you would ask, and the approach you'd use, I think is good to know as well.
And thank you, Marlene. Thank you so much. I always give you such a hard task of so much to cover in 1 hour. We should know better to schedule more time, but that was
I talk too much.
no, it was a great presentation. And yes, we will follow up with Marlene's slides as well, and a recording of today's session so you can share it with your colleagues. And we appreciate you all being here very much. I'm just going to pop in our Sarah events page to promote our next session that is coming up on November the 12th with Casey Wolford. And her topic will be Disenfranchised Grief, Exploring the Importance of Spiritual Processing for Culturally Diverse Personal Support Workers in Canada. So hopefully some of you will be able to join us again. And thank you so much for your time today. And thank you so much, Marlene. It's always a pleasure to learn from you.
You're very welcome. If anybody, they can reach out to you if they have questions for me afterwards as well.
Absolutely. And thank you everyone for your participation. And I have new things to research and learn more about. So much appreciated. Take care, everyone. Thank you, Marlene. I'll let you get to your next meeting.
Okay, thank you. Bye-bye.